So yeah, just continue chatting in, and we'll go ahead and get started. So as always, you all are muted, just so that we can get, there's no distractions, but there's going to be a discussion later, and we would love to have you jump in and unmute to chat in with us, or you can always use the chat to kind of share comments or any kind of ideas that you have while we're talking about this. Keep your camera on if possible. I know it's close to the holidays. We have a smaller group, and but we like to make it feel cozy and kind of so it's a real community and we can see everybody if possible. We don't mind if you eat lunch, that's totally fine. If you would like a completion certificate to say that you have participated or get credit for these hours, please make sure that you're logged on with your name first and last. And then there's some other kind of things that we'll ask for you to do to get some feedback about the session a little later.
Just so everyone knows, sorry to jump in, but I'll be sending out the certificates for all sessions that'll list the number of contact hours you have by the end of this week to everybody who has participated in any of our sessions. So you will have up to 5 contact hours depending on how many sessions you've attended.
Great, thank you. So you'll keep track for them how many they came to.
Yes, we have.
They don't have to tell you.
We have the attendance from all of the sessions, and we'll get those sent out later this week.
Wonderful. So be on the lookout for that. Thank you, Robert. All right, next slide, please. All right, so you guys have already done a fantastic job of introducing yourself. I'm Skylar Bellinger. I'm a psychologist here at KU on the Telehealth Rocks and Can Do grant, and just I'm helping out facilitating. But I'll let Dr. Heisman Powell and Dr. Zhang say hello in just a minute, but they're going to be our presenters today. Do you want, Dr. Zhang, do you want to say hello now? I really jumped ahead.
No problem. Hi, my name is Alice Zhang, and I'm a trained behavior analyst. So I'm really excited to talk to you all. Dr. Heisman Powell.
Yeah, my name is Linda Heisman Powell, and I am a licensed psychologist and a board certified behavior analyst at the doctorate level. I've worked here at K Med Center off and on since I did my pre-graduate training back in the 90s. Came on fully as the director of community research in 2008. And am still here. So I'm glad to be here.
Great, thank you. And we'll go on to the next slide, please. All right, so today's agenda is similar. We're kind of introducing now, and then we're going to have a didactic presentation for about 30 minutes till about 12:35, and then we're going to have a group discussion from 12:35 to 1. And we don't have a case today, but we thought this would be a great opportunity just to discuss some other things that are on your minds, questions you guys have, kind of problem solve some other things. So we'll talk about that a little bit later. Again, when you see that level up sign, that means that we want you to think about how to apply this maybe differently or to a new population. We know that many of you have so much expertise and experience with many of these concepts, but thinking about how can I take that to the next level? And you can chat that in or just think through that. All right, next slide. Again, we're going to be asking for you guys to complete surveys so that we can improve our training based on your feedback and give you guys more of what's helpful to you. So you should receive an email from the telehealthrocks@kumc.edu email address with that survey. That would really help us out. It helps us to continue to get funding and to continue to make these sessions better. So we'd really appreciate if you could fill that out for us as well. Next slide, please. As always, the team today is going to try to provide the best recommendations based on evidence that is currently accepted within the profession. Next slide. Okay, so without further ado, Dr. Zhang and Dr. Heisman Powell are going to talk today about supporting youth with intellectual and or developmental disabilities. So I will turn it over to you guys.
Perfect, thanks. Well, I'm going to start off. One of the ways that Alice and I present together is we kind of tag team sometimes. So just know that we're going to take turns being the primary speaker, but we may jump in. If you have any questions, just put them in the chat. The first thing I'd like to do is say thank you so much for this close to Christmas, in the middle of all the excitement that's going on in our country, for taking the time out of your day to be able to join us. And if you have any questions, feel free to put them in the chat. Skylar, are you monitoring the chat?
Yes, I can help monitor the chat, and other folks usually help me out too. So we'll respond as quick as we can.
Perfect. And so, you know, if it's something that I'm talking about, feel free to jump in, right? So we're going to be talking a little bit about how to support youth with intellectual and/or developmental disabilities today. So next slide, please. A little bit of the overview of how we're going to do this. We're going to talk a little bit about really what are intellectual and developmental disabilities. We're going to talk about how to address challenging behavior, and a little bit about function-based behavior intervention plans. And then, of course, in the middle of COVID-19, we're going to talk just a little bit about some strategies that can work with online instruction, as some of you in school districts may be in the middle of a remote learning time in your district. So next slide, please. What really are intellectual and developmental disabilities? I know often these these classes of behaviors get linked together, but they're really kind of just two separate things. They do have some characteristics in common, though. When we talk about intellectual and developmental disabilities, really these are disabilities that are present at birth. So we may have some kids where they affect the trajectory of an individual's physical, intellectual, and/or emotional development over time, and it can cause functional impairment in 3 or more of the following areas. Now, we have kids that present to us that may have some kind of trauma, like a traumatic brain injury, or they have some kind of trauma in their life that affects their intellectual or their emotional development, that causes functional impairment in some of those different areas. But there's a difference between this class of behaviors that we call intellectual and developmental disabilities that are present at birth and those that are acquired, right? Like a traumatic brain injury, right? We can pinpoint that to a specific event that impacts these areas. So when you can pinpoint it to a specific area like that, it's not considered under this class of IDD or intellectual and developmental disabilities, because these are ones that are present at birth and move forward from there. Next slide, please. So there are different types of intellectual and developmental disabilities. Now, usually when we think of ID, the standard thing that we think about is IQ, right? And so these are the conditions that, if everybody knows, the standard or average IQ is 100, and there are standard deviations associated with that. And so it's a mean of 100 and a standard deviation of 15, which means if you are one standard deviation from the mean, you have an IQ of somewhere between 85 and 115. So if you're in the middle of that range, you are at the top of the bell-shaped curve, right? We're talking about the bell-shaped curve and how it comes out. In order to qualify as an intellectual disability, you have to be 2 standard deviations away from that mean. And so for those of you that are working in like home and community-based services, or you're at your CDDOs, or some of those case managers, that is where that IQ of less than 70 comes into play, right? Because in order to be able to blanket qualify for an IDD waiver, you have to have an IQ of less than 70, which then is 2 standard deviations below the mean, and that's your qualifying condition to enter into waiver services. So it may be associated with some kind of genetic characteristic or disorder, such as Down's, Fragile X, etc. or it could be associated with something like fetal alcohol syndrome, prenatal exposure, or trauma in birth. Now, when you have specifically a developmental disability, it doesn't necessarily have an IQ of 2 standard deviations below the mean, right? You could have an IQ of 80 or 85, which is 1 standard deviation below the mean, but you still have a disability that impacts development. So it's a broader category of disability that we think about, and it often has a lifelong impact on your ability to interact and acquire the skills that allow you to be independent in your adult life. One of the most obvious ones is autism spectrum disorder. When I first started out in autism, the prevalence was 1 in 10,000, and it's now 1 in 54. So 1 in every 54 live births today, by the time that child's 8, they're likely to be diagnosed with autism, right? So it's pretty prevalent. A question about.
Oh, I tried to answer it. You don't have to stop. I was just trying to provide an answer about if there was a disability present at birth, but maybe would it not be discovered until later? And so I was thinking that while there would be signs, sometimes it's not diagnosed until later, right? Because school is when you start to formally assess that learning and stuff. So I just wanted to clarify that it's not like you have to know for sure that it's there right when they're born, correct?
Right. And the other thing about that too, and I'm just gonna, thanks for the question, because when we're talking about developmental disabilities, just because you have like a global developmental delay, that doesn't automatically qualify you for services. So we have these 2 broad classes of services available to these kids. One is through our Medicaid system, right, or our waiver system, which is through like the autism waiver, access to EPSDT underneath state Medicaid plan. But you cannot qualify for the IDD waiver until you're 5, right? And often we don't diagnose intellectual disability until about age 5 because IQ, Skylar, correct me if I'm wrong, but folks are really reluctant to give a diagnosis of an intellectual disability prior to age 7. Right.
Yeah, I would agree. Like 7, 8, 9 is kind of the threshold of feeling more confident in those numbers.
Right. So there's challenges then with entry into the state insurance plan services, because if we can't diagnose an intellectual disability until like 7, 8, or 9, or unless it's obvious, right, based on repeated testing, et cetera, or other characteristics, like we know the child had prenatal exposure or something along those lines, it's hard to get some of those early services in place unless they're diagnosed with autism. Now, which then, coming back to what Skylar said, their first point of contact, if it's not infant toddler services, is not going to be until they're in the schools, right? So that's where you first start coming in contact with developmental disabilities. So you have kids that have a hard time learning because of this developmental disability. You add on to that sometimes they don't have early intervention, and now throw COVID-19 on top of that. So it's likely that for those of you that are working in school settings or home and community-based settings, you might be presented with children that have behaviors that are exacerbated by the context of 2020, which I don't know how many are on here are excited for December 31st to come around, but I'm personally really excited that come January 1st, it will no longer be 2020. Next slide. It's also really important that you do a differential diagnosis between intellectual and developmental disabilities and mental illness. And that becomes somewhat that differential diagnosis more difficult as you're trying to ferret out, is this a developmental disability? Is this autism? Is this perseverative behavior that's associated with autism? Or is this a mental illness, right? And so that dual diagnosis becomes more difficult as our kids age, or especially for some of our higher functioning kids. I was just on a work group where we talked about the lack of ability for us to successfully diagnose comorbid mental health in individuals that have intellectual or developmental disabilities, especially if they're not verbal or they're lower functioning. It doesn't mean that they don't have mental illness. It's just that our ability to be able to diagnose them is limited. So when we think of IDD, it's typically occurs, it's pretty obvious in early childhood, whereas mental illness sometimes doesn't become apparent until adolescence, right? And we get maybe childhood onset schizophrenia, or that's maybe when bipolar disorder starts to become obvious. Mental illness can occur at any point in an individual's life, and it has nothing to do with intelligence. So next slide, please. So some of the things that we can do when we're coming in contact with folks with intellectual and developmental disabilities is keep language simple and concrete. As you can tell, it's like I talk, right? I like to talk. I like to use my hands to embellish what it is that I'm saying. You can ask me a simple question and I go all the way around it, and then I'll come back and I'll say, okay, that's the short answer. And everybody typically laughs because I'm very verbal and I want to explain to people what it is that, the underlying currents in the question that they asked. When I'm working with kids with intellectual or developmental disabilities, I can't do that. Because if I do that, they get lost. They get lost in the language, right? It would be like me trying to go sit and listen to, sit through a lecture on Einstein's theory of relativity. I would get lost after about the first 3 sentences, and then I would tune out. So it's the same thing with our kids that have IDD. We want to make sure we keep our language simple, concrete. When we ask them a question, it should be a simple question without additional clauses built into it. And we also need to make sure that we allow enough time for them to process that information and respond. One of the best ways to be able to get problem behavior in some of our kids is to keep asking them questions, not give them time to respond, or expect a response that is more sophisticated than they have the ability to provide. So the other thing that this third bullet point is really important, because sometimes what I hear, now remember, excuse me, if we cannot diagnose some of these conditions until the kids are 7, 8, or 9 years old. I remember back when I was in diagnostics at the CCHD here, and I would get parents and school teachers, personnel, case managers coming in, and I would hear the phrase, they seem to be willfully disobedient. And really, what come to find out, the kiddo has autism, or they have poor receptive language. And so when we have kids that have splinter skills, so they may have really good verbal language, but their receptive language is low, right? Sometimes they may appear to be willfully disobedient, and we're assuming that they're being uncooperative when actually they're not really comprehending what it is that we're asking of them or saying to them, right? And I think probably one of the biggest things is to make sure that we establish meaningful relationships with these guys, because they often don't have the sophisticated social behavior to be able to establish meaningful relationships with those in their environment. And so I think it's really important for us as these caregivers and these mentors and these people that are engaged with our folks that have intellectual and developmental disabilities. Even now, I mean, I've worked in this field for, 30 years. And even now, if we have somebody with an intellectual or developmental disability in the room with us, we often talk around them. So I will talk to the other person in the room that's their caregiver or their service provider, their supportive home care provider, their para. And I talk about them as if they are not there, right? And so it's incumbent upon us as the nurturers in their environment, the educators, the supportive staff that is there, that we pull them in and include them in that conversation, and we develop a relationship with them that goes beyond the fact that they're a person with an intellectual developmental disability, and not let that IDD label define them, right? We need to define them as a human being first that has a condition, so we pull them into the conversation. Next slide, please. Alice?
Yeah, so it's really hard to follow Dr. Heisman Powell. I just want to keep listening to you talk. So we talked about how interaction strategies with individuals with IDD, but also a lot of times there are challenging behaviors that tend to happen due to all those difficulties that I have mentioned in terms of communication and receptive language. So a lot of times we may see common challenging behaviors like crying, yelling, screaming, or more severe ones such as property destruction, aggression, self-injuries. I'm sure many of you who were in previous ECHO sessions heard that, we have some really young children who are 5 or 6 years old, but they are already having pretty severe challenging behaviors. Sometimes that would involve like multiple people, families, parents being called into the school to handle those behaviors. So we just want to talk about a little bit. Again, we acknowledge the difficulty of handling those behaviors. And next slide, please. We want to talk about what we can do to better handle those behaviors. So we kind of already talked about those strategies throughout our ECHO sessions, but just to reiterate, so there are things we really don't want to do, which is, we don't want to, attempt to reason or problem solve with a child who is already escalated, who is crying, who is throwing things or flopping on the floor. We don't also want to be showing we are overly concerned. Like sometimes we are caring people. We want to say, are you okay? Is everything okay? How can we help you? But that sometimes really also shows that you are giving that valuable attention to those behaviors. And
so
also,
Alice, I'm gonna jump in a minute.
Yes.
And there is, I'm pretty confident that 90% of you on this call have heard this phrase before. You can't reason with a drunk, right? So if somebody is not in their right mind, you don't try to bring logic into that interaction. And so it's the same thing what Alice is talking about. If you have a child that's already emotionally elevated, right? The chances that you're going to be able to reason with them to try to talk them down is significantly diminished, right? So it's important that you go into that interaction. Somebody in here said, don't get too close. But when you have a child that's really emotionally elevated like that, or physically, they're demonstrating their elevation through physical means, you don't want to feed into that situation, right? You want to employ other strategies to be able to de-escalate that. Sorry, Alice.
No, absolutely. Feel free to chime in anytime, Linda. So I'm looking at the time, so I'm kind of talking really fast. So also we don't really want to make comments regarding the behaviors, and that speaks to us adults, but also sometimes peers as well. So I always think it's a good social skills to teach other students to not comment or to not all get over there and watch someone having a tantrum. I think that's a really good social skills to teach. And also, we don't want to reprimand to say, why did you do this? Stop it. No, all those things are not going to help. And another thing is show your frustration. Sometimes we are frustrated. Yeah, absolutely. When things like escalated situation happens, we are. But it's really that, like, maybe just through your facial expressions, then the child may pick up on that, and knowing that their behavior has an effect on you, particularly if that function of the behavior is attention seeking. Next slide. So what should we do? So again, stay calm, which is really, really hard when you have so many students in your class and you're managing more than just that one child. And I know that's really hard, and that sometimes happens to us as well. So I think it's really, really, really important to give yourself a moment to just take a deep breath. And you do not have to react or respond right away. So after you take a deep breath, making sure you have calm voice, you have calm facial expressions, and trying to minimize your attention to the child who is engaging in any challenging behavior. And most importantly, follow the behavioral intervention plan if the child already has one. Next slide. So I'm just going to be really quick here. So I just want to emphasize that behavior intervention plan needs to be function-based, based on functional behavior assessments. And I have a link here, and also later in the resource, the TASN. They are a great place for technical assistance and support for school districts who need help with functional behavior assessments. Next slide. So antecedent strategies. So antecedent strategies are just things that we can do before the behavior happens, and how we can make the problem behavior irrelevant. So I want to make sure, Linda, if there's a slide, it's yours. Please jump in. I'm already lost track. So really providing that free or non-contingent reinforcers, no matter whether it's your attention, whether the child really likes certain of the function of it, access certain tangibles like toys and things like that. We want to provide that free on a time-based schedule. So for example, you stop by and talk to a student every 5 minutes for a student whose function was accessing teacher attention. The goal is that there's no need for that student to try to, scream or throw things at you to get your attention.
I am going to jump in for a second, Alice.
Yes.
Could you go back to the previous slide for me? When you're working with a group of people and you have an individual with IDD that has behavior that necessitates a behavior intervention plan, you do have to understand and implement the function-based behavior intervention plan. Because now go to the next one. When you're trying to give them free reinforcers, if you don't know what the true function of the behavior is, you're not going to be able to give them the reinforcer for free, right?
Absolutely.
So if you really like gumballs, and every time you walk by somebody, they give you gumballs, you don't have to deck them in order to be able to get a gumball, right? Because you have them for free. But you have to know that the function is access to gumballs before you can give them free gumballs. So that functional behavior assessment that you do in order to be able to develop the behavior intervention plan, to know how to make the problem behavior irrelevant, is really, really an important and critical component of being able to get to what is it that we do in order to minimize the probability that a problem behavior is going to occur. So,
yeah. Absolutely. So another point that's really important is to teaching the replacement behavior. So we teach them the behavior that they can, raise their hand, say, excuse me, before they have problem behaviors. Then this way they are going to be able to use those behaviors to access the reinforcement correctly, appropriately. So that is super important. Next slide. Again, when we teach those replacement behaviors, we want to really reinforce. We want to make it like a greater deal for them to use those appropriate behavior to gain more reinforcement than they were able to use problem behavior. So that can outweigh that problem behavior, the reinforcement they can gain from there. There are other consequential strategies, such as response cost, overcorrection, time out from reinforcers. I'm sure a lot of you are already aware of those. But the most important one here, I want to emphasize, is stop providing reinforcers for the behavior, which is one behavior principle called extinction. And if we continue to provide reinforcer to that problem behavior, we are never going to be able to completely replace that problem behavior. So I think the next slide are some graphs that Dr. Powell.
Yeah, so in talking about extinction, the definition of extinction, I'm pretty sure everybody knows what extinction is. Oh, place that behavior on extinction, right? But the definition of extinction is no longer reinforcing a previously reinforced behavior. And so by definition, you have to know what the reinforcer is, right? If you don't know what the reinforcer is for that behavior, you cannot be effective at putting it on extinction. And so, so let's say that we have a behavior that's occurring somewhere between, I'm going to ask a question. I don't know how this works. So we have this behavior that's occurring between 7 and 12 times a session. What is the first thing that's going to happen when you use extinction as a strategy to address this problem behavior?
I guess chat in your ideas.
Yeah.
You have an answer. Or unmute.
Yeah, feel free to unmute yourself.
Janice, I think got it.
She did.
The behavior increases. And Dana did too. She said it escalates. Very good.
Yep, it does. And so next slide, please. So that is what we call an extinction burst. And it does. It increases in intensity, frequency. We see novel behaviors emerge. And we also see the reemergence of other behaviors that used to access that reinforcer. And so often when I go into a school and we decide that we're going to use extinction as a strategy, I get calls from the teachers or home and community based and the service providers, and they say, it's not working, it's getting worse. And I'm like, oh, that's exactly what I want to see, because it means we pegged the correct function, right? And so what you're going to see is you're going to see that extinction burst. And it usually peaks. And if you stay the course, then that behavior will decrease pretty rapidly, and it comes down to about 0. Now you'll see that little blip somewhere around day 30, session 32 through 33. That's predictable. And what you need to tell your staff that you're working with or your service providers is expect it to reoccur down the road. And when it does, you have to make sure that you do not accidentally reinforce it. Because if you accidentally reinforce it then the behavior is going to come right back, right? So it's also really important that your staff, if you're going to implement extinction, that your staff and the setting in which you're implementing extinction and the behavior is sufficient that you can effectively not attend to that behavior during that extinction burst. Because if you do, next slide, please, what you've done is you've just established a new baseline. So now that learner, that student, they know that all they have to do is ramp it up and they get what they want, right? So now the kids that you hear, they go from 0 to 100. That's exactly what happens. And so now, if you want to use extinction as a procedure, next slide, please. Now what happens during that extinction burst? Now it gets to the point where you cannot tolerate it. The individual can't tolerate it. The environment can't tolerate it, because the burst is so intense now that now you run the risk of serious harm or injury. And so if you're going to be using extinction as a strategy, there's a couple of things that you have to do. First is you have to make sure that the individual can, that all the individuals associated with that learner can successfully implement extinction as a strategy. And that in addition, extinction in and of itself does not teach the replacement behavior. So concurrent with extinction as a procedure, you also have to be teaching the replacement behavior. So next slide, please. So in summary, for the whole problem behavior portion of this, is that not only do you want to make sure that that problem behavior, first of all, you want to fill up their attention, their reinforcer bag to start with, right? Non-contingent reinforcement, they have access to it. They don't have to work in order to be able to get it. Sometimes that's not always possible, right? But concurrent with that, you also want to put up that roadblock so that problem behavior never accesses that reinforcer. Because if it does, it's just going to continue to occur. So when I talk about reinforcement, I talk about it in terms of like structural engineering. When you have a bridge, you put up reinforcement into that bridge, right? It's like a cross beam to reinforce the bridge and make it strong, so that when cars go over it, it doesn't collapse, right? You have that brace that reinforces the bridge. We're doing the same thing to behavior here. We're reinforcing it, we're making it stronger, we're making it more likely to occur. And so we don't want the problem behavior to occur, so we have to make sure we take that reinforcer away, right? By the same token, you always have to make sure that your learner has access to the reinforcer by using appropriate behavior. What is the more socially appropriate way to be able to access that reinforcer? And we have to actively reinforce that and make sure that individual comes in contact with that reinforcer initially almost every time that they use that alternative behavior, right? So every time the learner raises their hand in class, you call on them. Now you can't do that for the rest of their life because that's not practical. But to start with, as a beginning step in your behavior intervention plan, you want to strengthen or shore up that replacement behavior, and you want to ensure, you want to remove the reinforcer for the problem behavior and make sure that problem behavior never accesses that reinforcer. Next slide. So one of the things that I do is when I'm called in sometimes to troubleshoot behavior plans, I use this behavior plan checklist. Does your behavior plan have behaviors that are operationally defined? Is there a separate function listed for each behavior, or are they all members of the same response class? What are some of the antecedent strategies that you have in? What are the instructional strategies? Are those listed in your behavior intervention plan? What are your consequence strategies? And just looking to make sure that the strategies that you pick are based on function. And this is just a really good way, and we can make this available to you as a form if you want, that we can send out to you guys so that you can go back and check that if you have a consumer that is, that it seems like the behavior intervention plan isn't quite being effective, you can go back and troubleshoot it, right? And say, oh, does it contain these elements? And if not, then that gives you a point for refining your behavior intervention plan. Next slide, please.
Okay, I think we are getting close. We're a little bit over the didactic time. I will make sure we get it done soon so we can have time for group discussion. So just some tips and suggestions for online teaching. I know at this point, you probably are already expert and have done plenty of those. But just for the perspective from, supporting individuals with IDD or students with IDD, we really emphasize that you have a token or reinforcement system built in. So there are many behaviors that you can reinforce. So you can reinforce for remaining in front of the screen and using the iPad or computer. You can reinforce for remaining on task. And also really important is to have a potent reinforcer ready to be delivered by parents at the end of a learning session, because you are not going to be there, right? So there are a lot of reinforcers. There's a link here from a PBIS incentives for distance learning. They have a lot of great ways to reinforce children in virtually, but at the same time, some children may benefit really at the end of the session. Their parents give them a piece of candy or chocolate. So you can use all those type of things. Next slide. Here are some tips and suggestions for online teaching about how you structure a learning session. So this might be a suggestion for you, but in general, what we want is that we want to create a schedule for the client or for the students. So when you start the session, maybe you can do that with the child, depending on the age of the child. You can say, okay, for the first 10 minutes, this is what I'm gonna do. And the next 5 minutes, this is what we're gonna do. So you have the input of the child with your planned activities. That way, the child can have a say in this. They might have a say in what kind of activities they want to do as a reinforcement break. So also, we suggest that when you start working on anything or any serious learning, you want to interact with the client in a fun way first. So do something really fun, depending on the age, do some games or just chatting, and so that we can build in that good relationship. And like in the past, we talked about building relationships, no matter whether it's specific praise, reflection, behavior description, all those skills you can use here. And when we start teaching, we want to start with preferred tasks or easy tasks so that we can build the momentum and compliance. We do not want to throw in the hardest task of all the tasks the first thing you do, right? So you want to easy the way in there. Also, you want to mix some easy and hard tasks together. This way, it's not all hard tasks. The student can have some successful correct responses. The student, you do not have to correct them or give them feedback all the time. So that is really important. Another thing that is really important is really provide breaks more often than probably you would do in person. So, because we know how hard it is spending so much time on Zoom or on other virtual platforms to learn and to interact. So it is really, that Zoom fatigue is real. So let's make sure we have some built-in, breaks in there. But when we do have breaks in there, we want to be able to keep the students in front of the Zoom instead of having them to go, play basketball out there for several minutes, especially when you don't have another adult in the room with the students. Sometimes it's going to be really hard for you to get that student back to that screen. So it is suggested that you do those breaks with the students in front of the Zoom. So you can, there are many, many ideas. You can share your screen and play some YouTube video. You can play some, interactive game together. Also, it might be really great to work on social skills. So you might make some plan to set up an appointment with another student so that the student you are working with can have a social break to work on social skills. So those are just some ideas. I'm sure you all have other ideas, so please chime in the chat if you have other ideas. And the most important thing definitely is making sure that you have the parents or caregivers phone number on hand in case you need assistance for anything. So next slide. So the last slide here is just some resources, again, like Tizen, and then last time we also mentioned the speech language hearing clinic in the Lawrence campus. They do a lot of services for like all of those, speech language, audiology, and AAC. So if you have a student that needs help, I think they would be a great resource, and they have a lot of experience working with students with developmental disabilities. Also want to throw in here that Dr. Heisman, Powell and I both are working on the OASIS parent training program that we provide trainings to parents and also teachers as well. And also there's another resources for girls with autism and developmental disabilities from KU Medical Center as well, Girls Night Out, and also Families Together. I think they are a great resource if you need to share with a family how they can navigate the system, get a resource. So next slide. So the last thing I really want to say is that, you know, you are all caring people. That's why you are in the profession you are in. You want to help the children, students to grow, to learn, and thrive. So remember to take care of yourself, and you deserve a great winter break, and you have, learned along with us and helping your students learn. So I guess that's just really want to say self-care is also really, really important. Next slide. So, here are the key takeaways. So if you can chime in, what are your key takeaways from today are, and how you're going to practice, that'd be great. Next slide. So Skylar, I'm going to turn it over to you.
Okay. So just to recap kind of what we've done on this journey together on Back to School for Better Behavior this year during the pandemic. We started out by talking about supporting youth with disruptive behaviors in October, and then moved on to supporting youth with anxiety and depression. We also talked about supporting children and families impacted by trauma. And then last week, we talked about building routine and promoting social engagement for our kiddos. And then this week, you just heard us talk about supporting youth and with intellectual and other developmental disabilities. So with that kind of quick overview, we just kind of wanted to open some things up to you to either unmute or chat in. But what can we do to continue to support your needs related to the topics that we discussed in this echo? So chat in, would it be helpful to do additional echoes or different types of consultation, technical assistance, other types of resources that we could develop or share? So just kind of chatting in or unmuting and letting us know what maybe has been helpful, and then what are the things that you would continue to need to support this topic.
Yeah, please feel free to chat in, but also just unmute yourself. I feel like we have been a very consistent group of people, and it's really just, we want to hear from you.
So some good feedback about like the concrete tools given when working with students. That's definitely something that we can keep in mind and continue. Anything else that you guys feel like you need when we're working with these students that we, either we haven't provided or just that you don't really have in your toolbox in your districts? Or I'm seeing the resources have been helpful. Yeah, and like Dr. Swells was saying, if there's any different topics or any information you'd want more in-depth information on. Everybody wants that behavior form, Dr. Heisman Powell, so we need to make sure we send that out when we send out the our email, when Robert sends that out a little later.
I have I have two. I'll send out both of them. One of them is that behavior plan, And the other one is a form that you can modify to troubleshoot if your plan's not working, or if the child still has problem behavior. So I'll send both those out.
We have a request for the slides, so I don't know if that's an option.
Yeah, we will send out the slides along with the chat, since we had, of course, some great recommendations in the chat today as usual. We'll get that sent out along with the certificates of participation.
Yeah, I'm hearing the theme of parent engagement, so that's really interesting. We have talked about in the past figuring out ways to incorporate parents more into these sessions. And so there's challenges that come along with that, but I think that's also a really exciting opportunity. So it would be kind of cool, maybe diving into that a little bit more, and then maybe having a couple of parents that could give us some of their perspective on, you know, how to do that and how to make that more successful. So that's a really interesting idea. Thank you for sharing that. Also, again, hearing more about you know, disruptive behaviors. I know that's just always a thing that's always on the top of your mind, since that's something that you have to deal with often, and that really does get in the way of learning. So let me pivot and see. Was there anything that we did not discuss? We talked about parent engagement, but that would have been helpful that you guys can think of? Is there any behavioral issues that you all saw in your schools or your settings over the last few months that we did not talk about or we did not touch on? Because we would love to hear if there were certain kind of common behaviors or common concerns going on with kiddos during this unusual time that we maybe didn't talk about or didn't touch on.
There's a comment about parent engagement impacted by trauma, and also just how to get parents involved with their child's education.
Mm-hmm. That's a really interesting topic. We'd have to really, I don't know that that's like my area. You know, I'm just trying to think who we could try to recruit that would be really good at that.
I've got some ideas spinning in my brain. So this will be a fun topic, I think, that could have some possibilities. I was about to message you back, Miranda. You know, when you suggest something, sometimes that means you want to help put it together. So I guess that was my jokey way of saying, you know, if there's any of you guys from the school teams, you know, I work at a hospital, and so I have a lot of perspectives on mental health and parent engagement, but more from the medical side of things. And so I think it'd be really interesting to have some teachers or people who work in the education setting participate in that, as well as, like Skylar was saying, some parents or parent advocates, because I really think it's all three pieces of that puzzle that might come together to help figure out how best to help make that connection engagement happen between parents and schools.
Yes, we had a big shout out to the folks who presented cases. So I wanted to, again, give you guys huge kudos and send you our gratitude for the folks that were brave enough to present cases, because I know it's challenging, a little challenging and overwhelming, and but it's so helpful. I mean, I'm sure that you guys all agree that we learn so much more when we discuss real cases, and we can learn from each other. And so we really appreciate that. I always learn so much hearing from you all and all the really innovative, creative things you've figured out doing. So I was curious if there's another question would be, is there something that you guys have learned during COVID, or a challenge that you had to take on during COVID, and was there, and letting us know how you guys solved that? I feel like that's a really big question, but is there kind of a general theme you can think of some challenge that came up during COVID, and how your team was able to problem solve that or address that? And that's kind of a big question.
Yeah, we just would like to hear some successful stories as well. Cheer us up at the end of the year and also at the end of the semester.
You guys are always so good at problem solving things, but I know it's probably hard when you're put on the spot. It sounds like,
go ahead.
I was gonna say, it sounds like maybe parent engagement maybe was a struggle. I don't know. So that we could continue to talk about that. But Donna says when students have on masks and have a speech issue, yes, that would be that would be very challenging. Was there any way you were able to address that, Donna? Was that something you guys figured out? I don't know if she's able to chat out. I don't know that there really is a great answer probably for that one, but
I think Donna chatted in that she just moved way back and asked them to take their mask down.
Okay. Future echoes, needing parents that need resources and respite. Absolutely. So maybe just like, yeah, that idea of parent support or engagement. Angry students.
I just want to go back to the question about students who have like speech problem and then wearing mask. So I forgot where I encountered that recently, but I was told that there is actually face mask that was connected by magnets. So basically when they speak, this can open, but when they close their mouth, the magnets connect together. I might have heard from one of you guys or somewhere else, but there are.
I feel like that would let their respiratory droplets out though, because when you're talking.
So there are masks out there, and we just ordered some for that community agency that I'm involved with. And it's the middle part is clear. So when you're working with a student, especially like speech language paths, and you're trying to get, you're working on language production, they can see your mouth, right? So so they do have those available.
That's a better idea.
I also wanted to we were talking about success, so I wanted to go ahead and share some of those things that came out, and I totally have heard this over and over. So, I think everyone is really worried about getting students to wear masks, and Anne was saying that the students in her building have been really resilient in wearing their masks and better than us adults, and I would totally agree. And so I feel like that has kind of been a success of the pandemic, is just how resilient kids are, and I think we all thought some of the kids with behavioral problems, and I'm sure there was some of that, but I just didn't hear much this year, which was pretty fun. I feel like that everyone the kids just figured it out and, have just such a great attitude about things. So I feel like their resilience has been really great. And then I think Dana mentioned that the kids aren't falling behind, that they're learning how to survive a pandemic, and that everybody's learning about empathy. And I love that. So I feel like that's a great way to end this, is really just kind of talking about the resilience of the students, but also the resilience of all of you, that everybody has just had to figure all this out and has just done an amazing job juggling, a million different things, teaching a million different ways, just figuring out how to support kids in this really, really strange and challenging time. So I think we should all leave this feeling really, really great and proud of ourselves, and just hopefully empowered that, like Dr. Heisman Powell said, hopefully next year 2021 will be better, and we've all learned a lot of lessons, gained a lot of empathy and resilience and strength. So
Sanita, can you move to the last slide? There's a little bit information. Keep going.
So again, we really want to thank you for being such an active part of our ECHO learning community. We want to wish you a wonderful holiday season. Please come to telehealthrocks.org. That is our kind of toolkit website, and we have, all of the echoes recorded there. We have lots of checklists and different kinds of resources and tools for all different things. So that's a great place to find resources. Subscribe to our YouTube channel, and we'll have all of these archived for you. And as we mentioned before, stay tuned for emails from telehealthrocks@kumc.edu, because we're going to be sending out stuff with your certificates, with the post-assessment survey, and with information about those next echoes.
And the checklists.
And the checklist, yes, about that Robert mentioned, that we will be doing that medical complexity echo starting in January. Is that correct, Robert?
It is. It'll be 5 sessions. It'll be really exciting. We have 2 pediatricians that focus on medically complex children, along with a clinical psychologist. So really excited to offer that, as well as hope you guys will reach out to your school nursing staff and others that also are impacted and work closely with the medically complex children.
Okay, well, it is, oh, and then Dr. Nelson wanted to remind us too that you are all welcome to join. There's a monthly resilience echo that's really focused on resilience and self-care for all of you who care for everyone else. So that's something that you're always welcome to join. We really want you to continue to be a part of our echo community. So it is 1 minute
Resilience
past.
Echo will continue through April, so there's still plenty of time to participate.
Wonderful, and you'll send that out too on the, maybe
Sure,
in the
we
next
can
email
send
with
out the information on the Resilience Echo as well.
Okay, sounds good. All right, well, thank you all. Have a wonderful break.